Welcome to this KQT Health Learning Management System lesson for blood products administration for medical transport. Please adjust your device volume so you can hear the material as it is presented. At the end of the lesson, you will need to complete a quiz about the material. The quiz will be available on your employee portal system. This lesson is intended to prepare advanced EMS providers to complete non-emergency medical transports of patients receiving blood product administration that was initiated at the referring facility. This lesson does not meet the educational requirements for the emergency administration of blood by EMS personnel for acute hemorrhagic conditions in the pre-hospital setting. It is recommended that all advanced EMS providers complete the Train PA course Blood Administration Protocol 6E95. In this lesson, you will learn the following: anatomy and physiology of blood, review the blood typing system, identify different types of blood products and their appropriate uses, describe the indications for administering blood products in the pre-hospital setting, describe the proper techniques for administering blood products. Identify potential complications associated with administering blood products and appropriate management strategies. Documentation requirements for blood administration transports. Blood is a specialized body fluid that moves through the circulatory system, transporting nutrients, oxygen, hormones, and waste products throughout the body. It is composed of plasma and formed elements that include erythrocytes, white blood cells, and thrombocytes. We will explore each of these components closer as we move through this lesson. The amount of blood in a human body varies depending on age, weight, and sex. On average, a person has about 10 pints, or 5 liters, of blood, which is roughly 7% of their total body weight. Blood production in the human body is an ongoing process happening at different rates for different components. Here's a breakdown. Overall blood volume. Your body replaces the fluid volume of your blood quite quickly, typically within 24 hours of any blood loss. Red blood cells. These are constantly being produced and replaced, with millions made every second in your bone marrow. However, it takes about 4 to 6 weeks to completely replenish red blood cells after a donation, which is why there are waiting periods between blood donations. White blood cells and platelets. These are also produced in your bone marrow, but at a faster rate than red blood cells. Their levels typically return to normal within a few days after blood loss. So, while your body constantly makes new blood cells to maintain circulation and oxygen delivery, the time frame for complete replacement varies depending on the specific component. Plasma is the liquid portion that transports water, nutrients, hormones, and waste products throughout the body and accounts for about 55% of total blood volume in the human body. The cellular elements of blood, therefore, make the remaining 45% of blood volume. The cellular elements included: erythrocytes, also known as red blood cells, are responsible for carrying oxygen from the lungs to tissues throughout the body. Red blood cells contain hemoglobin, a protein that binds to oxygen. Red blood cells make up the vast majority of cells, typically around 40 to 45% of total blood volume. Leukocytes, also known as white blood cells, are part of the immune system and help defend the body against infection. There are several different types of white blood cells, each with a specific function. White blood cells account about 1% of total blood volume. Thrombocytes, commonly referred to as platelets, are tiny cell fragments that are involved in blood clotting. They clump together to form plugs that seal off blood vessel injuries. Platelets are even fewer than white blood cells, present in very small numbers, typically only about 0.15% of total blood volume. The most common blood typing system is the ABO system, which classifies blood into 4 types: A, B, AB, and O. In 1900, an Austrian scientist named Karl Landsteiner conducted experiments mixing blood samples from different people. He observed that in some cases, the red blood cells would clump together or agglutinate when mixed with serum, the liquid part of blood, from another person. This clumping is due to a reaction between antigens on red blood cells and antibodies in serum. Landsteiner's experiments led him to identify three main blood groups, A, B, and O, based on these agglutination patterns. He also discovered corresponding antibodies in the blood plasma. The following year, Landsteiner's colleagues Landsteiner and Emil von de Castello identified a fourth blood group, AB, which has both A and B antigens on red blood cells. Landsteiner's work laid the foundation for the ABO blood group system, a cornerstone of safe blood transfusions today. Type A blood has an A antigens on the red blood cells and anti-B antibodies in the plasma. Globally, around 35 to 40% of people have type A blood. In North America, type A is present in 40 to 45% of the population. In Europe and North America, type A is the second most common blood type after type O. Type B blood has B antigens on the red blood cells and anti-A antibodies in the plasma. Globally, around 10 to 20% of people have type B blood. In North America, type B is present in 8 to 11% of the population. A significant advantage of type AB blood is the ability to receive blood transfusions from all ABO blood types. This is because type AB individuals lack the A and B antibodies in their plasma, so their immune system won't attack foreign red blood cells. Type AB blood has both A and B antigens on the red blood cells, but no antibodies in the plasma. Globally, around only 3 to 5% of people have type AB blood. In North America, type AB is present in only 1 to 2% of the population. A significant advantage of type O blood is the ability to donate red blood cells to people with all ABO blood types in emergency situations. This is because type O red blood cells lack the A and B antigens that can trigger an immune response in recipients with other blood types. Type O blood has no antigens on the red blood cells, but both anti-A and anti-B antibodies in the plasma. Globally, around 40 to 45% of people have type O blood. In North America, type O is present in about 45% of the population. The Rh blood typing system, another crucial component of blood compatibility, works alongside the ABO system to determine safe blood transfusions. The Rh system focuses on the presence or absence of specific proteins on the surface of red blood cells. The most important protein in this system is the Rh factor, also known as the D antigen. People who have the Rh factor on their red blood cells are Rh positive, while those who lack it are Rh negative. When it comes to blood transfusions, Rh compatibility is just as important as ABO compatibility. Rh positive blood can be transfused to Rh positive individuals without issues. However, transfusing Rh positive blood into someone who is Rh negative can cause a serious reaction. The Rh system is complex and includes more than just the Rh factor. Several other Rh antigens exist, but the D antigen is the most significant for blood transfusions. The groundwork for the Rh system began in the 1930s with research by Landsteiner and Wiener. They were conducting experiments involving blood samples and used rhesus monkeys in their research. This led to the discovery of a new antigen, later named the Rh factor, present in the red blood cells of most people. Landsteiner and Wiener, along with Levine and Stetson, published their findings in 1940. They definitively linked the Rh factor to a severe reaction experienced by some patients who received blood transfusions. This established the importance of Rh compatibility in transfusions. The discovery and implementation of the Rh blood typing system have significantly improved the safety of blood transfusions. In blood transfusions, healthcare professionals will prioritize using matched blood whenever possible over using type O blood. Matched blood minimizes the risk of immune reactions. When the blood type is matched with the donor's blood type, both ABO and Rh, the body is less likely to recognize the transfused red blood cells as foreign and attack them. This significantly reduces the risk of serious complications like hemolytic transfusion reactions. Matched blood transfusions allow the transfused red blood cells to function more effectively in your body. They can efficiently carry oxygen throughout your system, maximizing the benefits of the transfusion. Type O blood plays a vital role as a universal donor in emergency situations. Since type O red blood cells lack A and B antigens, they are less likely to be attacked by antibodies in the recipient's plasma, regardless of their blood type, A, B, AB, or another O. This is crucial when time is critical and the patient's blood type cannot be immediately determined. Overall, matched blood is the preferred choice for blood transfusions due to the lower risk of complications and better functionality. However, type O blood plays a critical role as a universal donor in emergencies. During a medical transport of a patient receiving blood administration, the blood may be matched or it could be unmatched type O, depending on the circumstances of the administration. Matching, when done, will have been completed by the referring facility and established prior to transport beginning. Blood products commonly used in the medical transport setting, including packed red blood cells, PRBCs, fresh frozen plasma, FFP, fresh frozen platelets, and whole blood. The blood product being administered will be determined by the healthcare team based on the patient's condition and presentation. Your role during the medical transport is to continue the safe administration of the blood product while closely monitoring the patient for signs of reaction. Next, we will look at each of the blood products a little closer to better understand their uses. Packed red blood cells, PRBCs, also known as packed cells or concentrated red blood cells, are a blood product commonly used for transfusion therapy to restore oxygen carrying capacity in patients with anemia or acute blood loss. Here's an overview of packed red blood cells. Packed red blood cells are prepared by centrifuging whole blood to separate the red blood cells from plasma and other components. The separated red blood cells are then washed and resuspended in a small volume of saline or additive solution, resulting in a concentrated suspension of red blood cells. Unlike whole blood or standard red blood cell units, packed red blood cells have a reduced volume of plasma and other blood components, resulting in a higher concentration of red blood cells per unit. Packed red blood cells are primarily used for the treatment of anemia and acute blood loss in various clinical settings. Hemorrhagic shock to restore oxygen delivery and tissue perfusion in patients with significant blood loss due to trauma, surgery, or gastrointestinal bleeding. Anemia to improve oxygen carrying capacity in patients with chronic anemia due to conditions such as chronic kidney disease, malignancy, or bone marrow disorders. Packed red blood cells are also used in perioperative transfusions to maintain hemoglobin levels and tissue oxygenation during surgical procedures with significant blood loss. While packed red blood cell transfusions are generally safe, there are potential risks and complications associated with their administration, including transfusion reactions, transmission of infectious agents, and fluid overload, especially in patients with compromised cardiac or renal function. Fresh frozen plasma, FFP, is a blood component prepared from whole blood donations and stored at very low temperatures to preserve clotting factors. Fresh frozen plasma is prepared by centrifuging whole blood to separate plasma from cellular components, then rapidly frozen to preserve clotting factors. It contains all the clotting factors found in normal plasma, including fibrinogen, factor 2, which is prothrombin, factors 5, 7, 8, 9, 10, 11, and 12, as well as proteins such as albumin and immunoglobulins. Fresh frozen plasma does not contain platelets, red blood cells, or white blood cells, as these components are removed during the preparation process. Therefore, fresh frozen plasma is not capable of transporting oxygen throughout the body. Fresh frozen plasma is primarily used to correct coagulation abnormalities and replace clotting factors in patients with acquired or congenital coagulopathies. Indications for fresh frozen plasma transfusion include the treatment of bleeding or coagulopathy associated with liver disease, disseminated intravascular coagulation, massive transfusion, reversal of anticoagulant effects in patients receiving vitamin K antagonists, such as warfarin, direct oral anticoagulants, management of coagulopathy in patients undergoing cardiac surgery, liver transplantation, or other major surgical procedures associated with significant blood loss. While fresh frozen plasma transfusions are generally safe, there are potential risks and complications associated with their administration, including transfusion reactions, transmission of infectious agents, fluid overload, especially in patients with compromised cardiac or renal function. Fresh frozen platelets are a blood product used in transfusion medicine to prevent or stop bleeding in patients with platelet deficiencies or disorders. Fresh frozen platelets are prepared from whole blood donations, similar to fresh frozen plasma. After whole blood is collected, it is centrifuged to separate the plasma from the cellular components, including platelets. The platelet-rich plasma is then further processed and frozen at temperatures below -18 degrees Celsius to preserve platelet viability and function. Fresh frozen platelets contains a concentrated suspension of platelets, along with small amounts of plasma proteins and electrolytes. Platelets are small, disc-shaped blood cells involved in the formation of blood clots to stop bleeding. Each unit of fresh frozen platelets typically contains a standardized number of platelets, usually expressed as platelet count per volume. Fresh frozen platelets transfusion is indicated for patients with thrombocytopenia, which is a low platelet count or platelet dysfunction, which can result from various medical conditions or treatments, including hematologic disorders, chemotherapy or radiation therapy, liver disease, and massive transfusion. While fresh frozen platelets transfusions are generally safe, there are potential risks and complications associated with their administration, including transfusion reactions, transmission of infectious agents, fluid overload, especially in patients with compromised cardiac or renal function. Whole blood is a blood product that contains all the components of blood found in the human body, including red blood cells, white blood cells, platelets, and plasma, in their natural proportions. You should recall that red blood cells are responsible for carrying oxygen from the lungs to tissues throughout the body. White blood cells are part of the body's immune system, involved in fighting infections and foreign invaders. Platelets are small cell fragments involved in blood clotting and hemostasis, and plasma is the liquid component of blood composed of water, electrolytes, proteins, such as albumin and immunoglobulins, hormones, and nutrients. Whole blood is collected from volunteer donors through venipuncture using sterile collection bags and needles. Whole blood transfusion may be indicated in specific clinical situations where patients require replacement of all blood components simultaneously, such as massive hemorrhage, hypovolemic shock, exchange transfusion used in conditions such as sickle cell disease or hemolytic disease of the newborn, where replacing abnormal blood components with healthy ones is necessary. While whole blood transfusions are generally safe, there are potential risks and complications associated with their administration, including transfusion reactions, transmission of infectious agents, fluid overload, especially in patients with compromised cardiac or renal function. During the medical transport with administration of blood products, you are not starting the initial administration. During the medical transport call, you will be continuing the administration of the blood product that was initiated by the referring facility. The primary reason for transporting a patient with blood products being administered is to get them to the next level of care without the delay created by waiting for blood administration to finish before transport. As medical transport providers, we are not carrying and storing our own supply of blood products on the ambulance. The blood product used for administration will be supplied by the referring facility where the treatment was initiated. Blood transfusion reactions are adverse events that can occur during or after a blood transfusion. They can range from mild and easily managed to severe and life-threatening. In this next section, we will look at these different transfusion reactions that can result from blood administration. We will first be looking at the acute transfusion reactions, including febrile non-hemolytic transfusion reactions, allergic reactions, hemolytic reactions, and transfusion-associated circulatory overload. Febrile non-hemolytic transfusion reactions are the most common type of transfusion reaction, affecting up to 1 in 100 blood transfusions. They are typically mild and self-limiting. The exact cause of febrile non-hemolytic transfusion reactions is not fully understood, but it's believed to be an immune response to white blood cells or other cellular debris present in the blood product. These components are not present in red blood cell concentrates that have undergone leukocyte depletion. During febrile non-hemolytic transfusion reactions, the body's immune system releases cytokines, which are inflammatory mediators. These cytokines cause fever, which is caused by an increased body temperature, vasodilation, which can lead to chills, along with stimulation of the nervous system, leading to rigors or involuntary muscle shaking. Signs and symptoms of febrile non-hemolytic transfusion reactions include fever, which is the most common, chills, rigor, which is involuntary muscle shaking, headache, and myalgia, which is muscle aches. The effects of febrile non-hemolytic transfusion reactions are usually self-limiting and resolve within 30 to 60 minutes. Management is generally focused on symptom relief. If you observe signs and symptoms of febrile non-hemolytic transfusion reaction, continue the blood infusion and contact medical command for specific management directions. Febrile non-hemolytic transfusion reactions are rarely life-threatening, but can be distressing for the patient. Allergic reactions are another type of complication that can occur during a blood transfusion. Unlike febrile non-hemolytic reactions, they are caused by an immune response to specific proteins in the transfused blood components, most commonly plasma or platelets. IgE-mediated reactions are the most common type of allergic transfusion reaction and involve the immune system protein immunoglobulin E, IgE. Pre-existing IgE antibodies specific to donor plasma proteins trigger a rapid allergic response upon exposure. Non-IgE-mediated reactions are less common. These reactions involve other immune mechanisms and can be caused by proteins in red blood cells or white blood cells. The allergic reaction releases inflammatory mediators like histamine, leading to various symptoms. Signs and symptoms to observe include itching skin, hives, or rash visible on the skin, wheezing or difficulty breathing, nausea and or vomiting, abdominal cramps, dizziness and lightheadedness, chest tightness or chest pain, and rapid heart rate with a low blood pressure. Pause the blood infusion and immediately contact medical command for further direction on patient management. Possible treatments to anticipate from medical command may include the administration of antihistamines, corticosteroids, bronchodilators, or epinephrine. Maintain an open airway for the patient and support respirations as needed. Closely monitor vital signs and observe for changes in the patient's condition. Allergic reactions caused by blood administration can range from mild to life-threatening. Early recognition and prompt intervention are critical to prevent complications. Hemolytic transfusion reactions are the most severe type of transfusion reaction, occurring when red blood cells from the transfused blood are destroyed by the recipient's immune system. This destruction, or hemolysis, can happen within the bloodstream, intravascular, or in the spleen and liver, extravascular. The primary cause of hemolytic reactions is incompatibility between the donor and recipient blood types. This can occur due to ABO incompatibility, which is the most common cause, where the recipient's plasma contains antibodies that attack incompatible A or B antigens on the donor's red blood cells. The other cause is Rh incompatibility, which occurs when the recipient lacks the Rh factor and develops antibodies against Rh-positive donor red blood cells upon exposure. Hemolytic transfusion reactions can also be caused by minor blood group incompatibility, which are incompatibilities with other less common blood group antigens. Hemolysis releases hemoglobin, a component of red blood cells, into the bloodstream. Hemoglobin can have several detrimental effects, including kidney damage, anemia, inflammation, and disseminated intravascular coagulation, known as DIC, which is a severe complication where widespread clotting and bleeding can occur. Signs and symptoms of hemolytic transfusion reaction include chills and fever, hypertension, warmth sensation, back and flank pain, increased heart rate, constricting chest pain, hemoglobinuria, which is a dark reddish urine, and hyperbilirubinemia, which is a brownish color urine. If you see any signs of hemolytic transfusion reaction, pause the blood infusion and immediately contact medical command for further direction on patient management. Be prepared to support vital signs by administering fluids and medications to maintain blood pressure and oxygenation. Corticosteroids may be considered to reduce inflammation. Closely monitor vital signs and observe for changes in the patient's condition. Hemolytic reactions can be life-threatening and require immediate attention. Proper blood typing and cross-matching procedures are critical to prevent these reactions. Early recognition and prompt intervention are crucial to minimize complications. Circulatory overload, also known as transfusion-associated circulatory overload, or TACO, is a potentially life-threatening complication that can occur during or after a blood transfusion. It happens when the volume of transfused blood exceeds the body's capacity to handle it effectively. TACO arises from a fluid overload situation. It can occur due to rapid transfusion rates, pre-existing conditions such as heart failure, kidney dysfunction, or low protein levels, hypoalbuminemia. Transfusion-associated circulatory overload can also be caused by excessive blood volume transfusion. The extra fluid volume from the transfusion leads to increased pressure within the blood vessels, particularly in the pulmonary circulation. This can have several detrimental effects, including pulmonary edema, cardiac dysfunction, and edema formation. Symptoms of TACO can develop rapidly during or within 12 hours after transfusion. They include dyspnea that occurs at rest or when lying down, cough with the possibility of pink or frothy sputum, tachycardia, chest tightness or discomfort, jugular vein distension, peripheral edema, altered mental status, decreased oxygen saturation. If you see any signs of transfusion-associated circulatory overload, pause the blood infusion and immediately contact medical command for further direction on patient management. Be prepared to support oxygenation by providing high-concentration oxygen. Closely monitor vital signs and observe for changes in the patient's condition. Delayed transfusion reactions, unlike their acute counterparts, develop hours to days or even weeks or months after a blood transfusion. These reactions are often more subtle and can be challenging to diagnose. As a medical transport provider, completing a patient transfer of someone receiving a blood infusion, we want you to be familiar with these conditions. Here are the primary delayed transfusion reactions that could occur with a brief description of each. Delayed hemolytic transfusion reactions. This is the most common type, occurring 1 to 28 days after the transfusion. It's caused by the recipient's immune system recognizing and destroying incompatible red blood cells from the donor. Symptoms include fever, fatigue, jaundice, and dark urine. Next is transfusion-associated graft versus host disease, a rare but life-threatening reaction in which viable donor lymphocytes from the transfused blood engraft in the immunocompromised recipient, attacking the recipient's tissues. Symptoms include fever, rash, and organ dysfunction. This doesn't cause immediate symptoms, but can lead to future problems. Exposure to foreign red blood cell antigens during transfusion can stimulate the recipient's immune system to develop antibodies. This can cause hemolytic reactions in subsequent transfusions with incompatible blood. The medical transport case with active blood administration is intended to move a patient from the referring facility where the blood infusion was initiated to another facility where a higher level of care can be continued. Keystone Quality Transport will only transport patients with a running blood infusion that was initially at a medical facility prior to transport to another facility. Keystone Quality Transport will not carry blood products on the ambulance and initiate blood infusions in the pre-hospital setting. In this next section, we will look at preparing for the blood administration medical transport, beginning with the assessment and patient packaging. Once you have arrived at the referring medical facility, make contact with the patient's healthcare team. Obtain a patient report and review the patient's medical record documents. Confirm the destination location of your patient to be sure the information matches what has been supplied by dispatch. After receiving the report from the healthcare team, introduce yourself to the patient. Complete the identify, verify, and confirm process by identifying yourself and your partner. Then verify the patient using a two-identifier method, such as name and date of birth. Next, confirm the transport destination and obtain consent for transport. Complete your normal patient assessment as you would for any medical transport call. Obtain a complete setting of vital signs, including heart rate, respiratory rate, blood pressure, oxygen saturation, level of consciousness using the Glasgow Coma Scale, and temperature. Skin temperature alone is not sufficient. You need to obtain an actual temperature using a thermometer. Check the patient's vascular access site where the blood infusion is connected. An intravenous access for blood administration must utilize at least a 20-gauge catheter. Check the access site for patency and for signs of infiltration, which may include swelling, discoloration, pain, or tenderness around the site. Make sure the vascular access site is well secured for movement and transport. Next, turn your attention to the infusing blood product itself. Once again, Keystone Quality Transport is not initiating blood infusions in the pre-hospital setting. Keystone Quality Transport will only transport patients with a running blood infusion that was initially at a medical facility prior to transport to another facility. Identify the actively infusing blood product. It could be packed red blood cells, PRBCs, fresh frozen plasma, FFP, fresh frozen platelets, or whole blood. This information must be recorded in your patient care report. Identify the blood type and RH status of the infusion blood and document in your patient care report. Determine the remaining volume of blood product to be infused. When you encounter your patient with an active blood infusion in the referring facility, the blood product will most likely be on an infusion pump. The infusion pump will need to be discontinued, and the blood infusion will continue as a gravity drip during transport to the receiving facility. Blood administration is a special tubing type. The most notable difference is the Y connector that attaches to both the blood product supply and a saline fluid supply, which come together in a filtered drip chamber. It would be a waste of blood product to change the current tubing for the blood infusion to another set that is compatible with our transport infusion pumps. Therefore, Keystone Quality Transport will complete all blood product infusions using the gravity drip method. A typical infusion rate for blood products is 50 milliliters per hour, which equals 0.85 milliliters per minute. Remember, you will be removing the blood product from the referring facility infusion pump and switching to a gravity drip for the transport. Let's take a minute to review how to set up your IV for a gravity rate drip. First, if not already known, convert the milliliters per hour to milliliters per minute by dividing the milliliters per hour by 60. 50 divided by 60 and 0.83. This gives us a drip rate of 0.83 milliliters per minute. The next step is to determine the drops per minute based on the drip set being used. You should recall that the drip set will have a rate that says how many drops are in 1 milliliter. For this example, we will use a drip factor of 20, meaning that it will take 20 drops of fluid to equal 1 milliliter. Therefore, 0.83 times 20 equals 16.6. We round that up to 17, giving us a gravity infusion rate of 17 drops per minute. Now that you know the desired drops per minute to achieve the administration rate, set the drip chamber. Finally, secure the blood product and saline for transport. Ensure the tubing is loose and will not be pulled as the patient is moved to the stretcher. Now that your patient has been safely and securely loaded into the ambulance and transport is underway, we need to closely monitor the patient. Recall that hemolytic reactions are serious transfusion reactions characterized by the destruction of red blood cells, RBCs, in the recipient's bloodstream. These reactions occur when incompatible blood components are transfused, leading to immune-mediated or non-immune-mediated hemolysis. During the transport of patients with active blood administration, you must check and document a complete set of vital signs every 10 minutes. Continuously observe the patient for signs of hemolytic reaction. The clinical presentation of a hemolytic reaction can vary depending on the type, severity, and speed of onset. Common signs and symptoms include fever and chills, flushing, back or flank pain, chest pain, tachycardia, hypotension, hemoglobinuria, which is a red or tea-colored urine, jaundice, dyspnea, hypoxia, hemorrhage, or disseminated intravascular coagulation in severe cases. Management of a blood administration reaction is based on the severity of the patient's reaction. This table presents EMS action for the different reaction levels. We will review each section individually in the next few minutes. Mild reactions may present with a rash or itch. The rash or itch may be localized to the infusion site or develop in other areas of the patient's body. If the patient presents with signs of a mild reaction, continue the infusion and contact medical command at the receiving facility, if possible. A moderate reaction may present with a rash or itch. The patient would have stable vital signs but may have angioedema and/or stridor, or wheezing breath sounds. Angioedema is a skin condition that causes swelling in the deeper layers of the skin and tissue beneath mucous membranes. It can affect any part of the body, but it usually occurs in the face, lips, eyes, genitals, hands, and feet. If the patient presents with signs of a mild reaction, continue the infusion and contact medical command at the receiving facility if possible. Do not disconnect the blood administration tubing. Simply pause the infusion. A severe reaction may present with signs of hypoxia and evidence of shock, including unstable vital signs that include elevated heart rate and low blood pressure. If the patient presents with signs of a severe reaction, immediately stop the infusion and contact medical command at the receiving facility, if possible. Do not disconnect the blood administration tubing. Simply pause the infusion. Blood product administration typically takes about 30 minutes to infuse. Your patient's blood infusion may finish during transport to the receiving facility. If the blood product infusion finishes before you arrive at the receiving facility, take the following actions. Document the time the infusion finished. Leave the blood product administration tubing attached. Close all clamps for the blood product tubing. Obtain a full set of vital signs, including heart rate, respiratory rate, blood pressure, SpO2 reading, cardiac rhythm, and Glasgow Coma Scale. Upon arrival at the receiving facility, advise the healthcare team that the patient's blood product infusion finished during transport. After the transport has been completed and the patient has been properly turned over to staff at the receiving facility, you will need to complete your patient care report. You should complete your PCR as you would for any other ALS transport. In this brief section, we will look at specific documentation requirements for blood infusion transports. On page 7 of the EMS chart system in the Medical and Infusion Prior to Assessment section, you must document the following elements. IV location. This is a drop-down menu based on the information complete in the vascular access initiated prior to assessment section. Time the blood product infusion was initiated. In the medication field, document the blood product being administered. The dose and rate should be recorded as provided by the referring facility. In the activity log on page 8, use the Add Action button to add the blood product as a medication. You will need to complete the following data elements in the pop-up window. Blood product name, select the correct product from the drop-down menu. Dose and rate. Record the dose rate from the referring hospital and your calculated gravity drip rate. The route should be recorded as an IV drip. The response should be listed as unchanged unless the patient had a negative reaction. In the authorization field, you should document written order, patient-specific. Finally, in the comments section, write a statement that the infusion was initiated at the referring facility and continued during transport. Thank you for this KQT Health Learning Management System lesson on blood product administration for medical transport. If you have questions about the material presented in this lesson, please contact the clinical operations team. You may now take the associated quiz located in your employee portal system.